We go on to our next speaker, Dr. Siddharth Kumar, who's a phaco-refractive and a retina surgeon from Kumar Eye Center, Patna. So on to you, Dr. Siddharth.
Good evening, everyone, and thank you, Chitra ma'am, for giving me this opportunity to present my case. Yeah, is my screen visible?
Yes, yes.
Yeah,
yes.
is my screen visible?
Yeah, all good, sir.
So I'm managing a traumatic cataract. A patient is of 6 years old. He had a history of trauma by a stick injury, and the vision was in the left ear. Well, in the left eye was 1 meter is there, and the traumatic cataract was present. The capsule was ruptured, and the iris was the posterior synacle was present. We did the biometry, and we got the biometry in the left eye, and then we planned the surgery after a week, and we put the patient on topical medications and systemic steroids also. So here the surgery starts. As you can see, we are making a side port, and we are staining the anterior capsule with we are staining the capsule, and then we are putting a sodium halonate, and I'm releasing the synacle by the help of the spatula, and you can see over there. Now the capsular the nick has been made to make a capsular rhexis, and with the help of a microforceps, trying to make a capsular rhexis. As you can see over here, it has been run off a little bit, and then I'm giving a nick from the other side and trying to continue the capsular rhexis. This is how we have completed the rhexis. I'm now making a main entry, and now I'm doing a little bit of hydrodissection. And as you can say, it's a very fluffy, and just with the help of the IA, we can aspirate all the fluffy cortical matters. And the care has been taken not to engage the bag or capsular margin. The parameters are quite low over here. So all the precaution will be taken care while removing all the cortical matters. Now, after removing all the cortical matters, I'm trying to engage as much as the cortical matter, and then now I am putting a 3-piece IOL. As you can see that it has been flipped, so just flip the lens in the AC, and then I'm putting it in the bag. After putting all the in the bag, now I'm washing off all the viscoelastic. And now the all the side ports and the main ports will be sutured, as it's a pediatric case, so it needs to be sutured because of the elasticity. Yeah, now the case has been closed. A little bit of hydro was done. And a tricot is given at the end of the incision to take care of all the post-op inflammation. So, okay, I think I'll just run.
Thank you. Thank you very much.
Yeah. And this is the post-op picture. As you can see, after 2 weeks, the patient achieved 6/6 vision. Luckily, the trauma, the cornea was quite clear in the pupillary area, so the patient achieved 6/6 vision. Thank you so much for the patient hearing.
Very good case, Dr. Siddharth. Now, how do you plan what was the age of this patient? I missed that.
6 years, ma'am.
6 years. So how do you plan your IOL power calculation? Like, how do you do it?
Yeah, 5% reduction in the IOL power, which has whatever the calculation was coming. So 5% we have just reduced it for the myopic shift, because already the patient has almost achieving the age of 7, almost age of 7 to 8 years. So so we can just 10% reduction we have done it for that 5% reduction in that.
Something like a 7 minus age is a
Yes, ma'am.
way of going. And the
Yeah.
other thing is, did you do a hydro in this particular case? Did you do hydro?
Yes, ma'am.
You did. So I was just wondering, like in a traumatic cataract, unless you've done an ASOCT, theoretically, if you are not sure about the probable pre-existing PCR, whether you could even avoid doing a hydro in these cases. Would some of the expert panel agree on that?
I think hydro should be done very, very carefully. Without clear evidence of the intactness of the PC, hydro, if possible, should be avoided, because anyway these are very soft cataracts. And I think one more point that I would like to make is the timing of the procedure. So you need some gap to sort of get your IOL and everything ready. But at the same time, you should also consider the possibility of amblyopia. So you should balance between these two and do it off as early as possible. Some of these traumatic cataracts with a small opening in the anterior capsule, the cortex tends to get fluffy very fast. And so you shouldn't wait too long, and you should go ahead with your IOL procedure. Very good presentation, Dr. Siddharth.